before leaving the floor to the speaker and to our moderators, just a couple of things to mention. This webinar is being recorded, which means that at the end of the webinar, it will be available for everybody on our website. And just regarding questions, you will be able to ask all questions you want through the chat function. And that's all. It was very simple and short. I'm going now to leave the floor to our facilitators and the speaker.
Thanks, Anna, and good evening, everybody. Thank you for joining us for this ESSAC Research Academy webinar. It's my pleasure to introduce Debby Keller, Dr. Debby Keller, who is a leader in surgical research and innovation, having trained at Temple University Hospital in Philadelphia and undergone research and clinical fellowship training in Cleveland and further clinical fellowship training in Dallas and Houston. Dr. Keller went on to have a very successful practice in Columbia University and has recently moved to UC Davis in California, and has a strong interest in innovation and translational research. I'm delighted to welcome her to discuss her career pathway and tips and tricks for getting involved in surgical innovation and surgical education.
Thank you so much. I'm really honored to be here. Give me a second to share the screen. Started. So figured today that we would share how I got here, as you asked, discuss some of the factors that are driving change in surgical education and surgical innovation, concepts of the surgeon athlete that I like to speak about and push, and introduce tools for performance improvement in all phases of surgical education. So how did I get here? I became a doctor because I was a patient. I've actually had 11 abdominal surgeries already. And I knew that doctors could and should do better. I always had the surgeon mentality. When I was very young, I used to take apart watches and put them back together, much to my parents' dismay. I never had any patience. I was hands-on and very visual. And this drive for surgery was solidified for me in medical school and then followed surgery into residency training. Trained at a major high-volume trauma center, like Helen said, Temple, which is great for experience and great for confidence. But there was really little minimally invasive surgery and no talk at all about enhanced recovery. As a third-year trainee, Dr. Connor Delaney, who's like the colorectal surgery godfather, came as a visiting professor and spoke about ERAS. And for me, that was like a light switch going off. So I followed that light to Cleveland after residency to work with him and learn. It's a beautiful picture of Cleveland in the summertime. I did research and clinical fellowship there and had wonderful clinical and research mentors that helped me figure out my passion and my goals and love for innovation and technology and teaching. I think it's important, because we talk about mentorship a lot, to say that I had not had a mentor in the same institution since I left training. Few people actually do. And that's okay, especially in this digital age. And I want to encourage the young attendings on to reach out to others for help and for opportunities, and to create a team of mentors and sponsors for yourself to address all of your needs. And I just want to take a second here to acknowledge the people that mentor me and encourage my passions. The same passion that makes you special as a trainee can also make you a target as a young attending. And this is a painful reality in surgery. It's also worse for women. I've dealt with all of this, with being used, with the aggressions, the bullying, the discrimination, the retaliation for trying to help myself. It's sadly not uncommon, and we don't talk about it often, which help perpetuate this cycle. So I wanted to mention it. And when you're in these situations, you need to use your mentors and your voice to go back to your goals and remember why you're doing this and the things that bring you joy. So for me, it's innovation to improve surgical quality, patient engagement, and surgical education. So on to surgical education. The history of surgery actually dates back about 3100 BC, from the ancient Egyptians to the Indian Shishrata to the Greeks. Surgery was not a trade, it was a blunt profession. The most common method of training surgeons, if they were trained at all, was through apprenticeships. And the length of training and the starting age varied. There was no way of measuring competency or proficiency. It was literally see one, do one, teach one. As surgery evolved into a profession during the 19th century, the apprenticeship model remained the standard of surgery education. There were major innovations from Liston and Lister with anesthesia and antisepsis, but nothing for surgical education. And there were still no guidelines for what knowledge and skills should be taught, how long training should last. And by the end of the 19th century and beginning of 20th century, we saw the first shift towards a formal surgical training scheme. That model was introduced in the US by William Halsted and has remained dominant for over a century. Halsted trained initially in New York and then went to Europe, coming back to the US with ideas for optimal training from you all. He helped open the Johns Hopkins Hospital, which had the first associated medical school in the country. In 1900, he was made surgeon-in-chief there, and he started this formal surgical education program, embracing primarily the German surgical training. This training model had a defined structure and graduated increased responsibility with each year of training. There was this pyramid training structure where some residents would be eliminated every year, resulting in one super chief resident. And that was the start of surgical quality control. Halsted judged performance, and those that didn't excel were dropped. There was still no set time for training. Training lasted over an indeterminate number of years, and he decided when a resident was skilled and able to perform independent work. There were tweaks to this brutal system over the next 100 years. Regulatory agencies like the American College of Surgeons were established. And by the 1930s, they had a rectangular training program at Massachusetts General Hospital that finished the same number of residents that started. They also set the time for training, 8 years, and a set number of procedures that was required. And that was the norm for about the next 100 years. Until recently, several variables have collided: technical innovation, limitations to time in the hospital, and demands for increased patient and provider safety, which is forcing a change in surgical training. During this time recently, there's been major rapid technical advancements. Speaking from a colorectal standpoint, there's expansion of minimally invasive platforms in endoluminal, transanal, laparoscopic, and robotic platforms. Intuitive Surgical was born in 2003 from the merger of two competing companies, and the surgical robot as we know it was born. And this has been the major force until recently as the market is exploding. The robot was supposed to be the promised land for improving surgical performance. In the 1970s and 80s, robots were the model for QI, from Six Sigma strategies used in production lines. They were supposed to create the highest quality products consistently with little waste. And there was hope that robots would do the same in surgery. And the robot may help, but it's not the answer for quality. At least the robots currently available, as they're not smart. And performance still depends primarily on the surgeon's skill and the surgeon's training. Pair that with the need to improve quality. This was widely publicized in the US in 1999, when To Err Was Human was published and showed medical errors are a major issue. There still remains an outrageous number of medical errors annually in the US at a massive cost. And the knee-jerk reaction to this was changing resident education from a competency-based model to a time-based model. First cutting down the calls we took, then restricting us to an 80-hour work week with increased supervision, and then 24-hour maximums of continuous clinical assignments. And after years of this, there's no evidence that any of these regulations have actually cut down on medical errors, patient morbidity or mortality, or improved test scores or competency of trainees. To the contrary, residents report a loss of perioperative continuity, a decrease in operative volume, and they graduate feeling unprepared. And this is happening internationally. Studies have shown that 28 to 42% of residents or trainees graduate feeling inadequately trained to safely perform procedures. With duty hour restrictions, the variability of exposure to procedures, and the push to improve surgical quality, something has to change. Surgical education has to change because we're not going to change the need to graduate competent, safe surgeons. A novel training paradigm is necessary to meet this challenge and ensure that we're safe and competent. And I propose a better way is pre-training, performance assistance, and performance review, essentially training like an athlete. In nearly every task, there's a direct corollary between surgeons and athletes. By replicating the way athletes train, we can use performance improvement as a way to improve efficiency and quality outputs for the surgeon, the procedure, and the patient. Let's start with pre-training. Essentially, if you practice, you will know what your outcome is before you even walk in the room. So what do I mean by pre-training? It's practicing for the case or the event, including technical and cognitive skills, your strength, endurance, concentration and mindfulness, pain and fatigue strategies, and how to perform under pressure with situational awareness, and if needed, psychological counseling to remain at your best. Consistent evidence shows that experts are made, they are not born. Erickson described the 10,000 hours of deliberate practice necessary for mastery of a skill. Deliberate practice accounts for performance variation across sub-elite athletes, and the same case can be made for sub-elite surgeons. Deliberate practice pre-trains surgeons for their performance or their cases. And OR time is too valuable for practice and acquisition of technical skills. There's simulators, inanimate skill trainers, and animate models that are all validated ways to develop your skills and anticipation of your cases. But they're expensive, infrequently available, and inconvenient. Alternatives are available for the transference of skills in pre-training today. First, there's hands-on simulated environments, and this is not your normal wet and dry labs. Here you can map the steps of the procedure and start with pattern recognition for the procedures, gain familiarity with the equipment, the setup, and the steps of the operation. It also provides the ability to develop situational awareness and cognitive skills in a safe space that you can personalize to your needs. 3D simulation models increase the realism, allowing muscle memory to develop for the steps of the procedure and provide a tactile element that's more engaging for the surgeon. 3D can go even further with virtual reality for a fully submersive simulation of the task or operation, mapping the steps, even modeling them out in an alternative environment created for the case. VR-based tools incorporate checklist-style assessment measures to objectively gauge surgical proficiency, task, and taking the process outside of the realm of surgical human subjectivity. These tools offer a highly granular picture of what surgeons are doing correctly and can identify tools for improvement. They also give unlimited repetition and a personalized experience so that you can perform your best. Purchase of these tools may have previously been prohibitive, but platforms now work off simple headsets that you can create out of cardboard or buy for $200 at any electronics store. And research is starting to come out showing the significant improvement in pre-learning with virtual reality. Social media is also a recognized learning tool. There is no tool that can compare to the depth of information offered or reach of social media. With social media, in addition to finding curated research from specific hashtags, you can engage with subject matter experts and present cases in real time across time and space on a free, equitable platform. Surgeons are capitalizing on these benefits with Twitter and closed Facebook groups to maintain privacy for patients. And with the use of apps, images can be recognized and thereby linked to appropriate video demonstrations, which can subsequently be played on smart devices, really bringing cases to life. This engagement is proven to increase the learner's understanding of material. There are dedicated surgical teaching apps that are available. Apps can offer didactic chapters, guidance from experts, detailed medical illustrations, 3D animation, and colorized videos demonstrating key concepts. Here's an example of the iLap app, which focuses on the procedural steps of the transanal TME, the embryology and anatomy, and optimal pathway to implement the procedure safely. These are free, convenient, personalized to the learner, and an adaptive environment to discover updated content in an electronic format. It's literally a portable book that's come to life for you. Apps can also help you develop cognitive skills, not just technical skills of the operation. This is one that we developed that works to assess and improve the intraoperative judgment, gauge your level of confidence. It asks you where to start for a dissection, then presents a heat map comparing your annotation to expert levels with or without distractions in the background. It also compares your performance with a sample of your peers by experience level. Again, these are free, convenient, and adaptive to the individual learner's needs. And as a surgeon, this is your playbook: real-time virtual learning. It's the ultimate in live and personal delayed live training. You can virtually attend live cases. You can review and interact with videos. It can allow you to connect with experts. It enables skill transfer and personalized pre-training to ensure that you can perform on your surgery day. It also helps you to review your team and your opponent, the patient's comorbidities, so you can know the strengths and the weaknesses before you walk into the room. So then we move to the performance after you're pre-trained, which is essentially what tools can we use in the operating room to help us have the best outcomes. Fluorescence angiography is one tool. Fluorescence angiography uses a fluorophore that binds to proteins in endothelium. The special scope excites the fluorophore in the UV light wave, and it can be overlaid on the operative field to help determine the extent of resection or the vascularity. It can be pushed further to quantify the degree and speed of uptake to correlate with perfusion, the heterogeneity in O2 uptake, and venous outflow of the tissue. But we can also think smarter with this. It can be used to help guide anatomy, like the ureter, which is priceless in difficult cases, and the tumor, which can be tagged with tumor antigens for disease identification and identification of malignant nodes, or injected around a tumor, the lymphatic map in the mesentery, and to find aberrant nodes that we may have otherwise missed. 3D modeling during the case can also help simulate complex anatomy to prepare for cases, and VR can be used to have an interactive environment with the models and imaging available for assistance during the case. This is a video from friends at St. Mark's doing a complex fistula repair, where the 3D model comes live in front of them, as well as the MRI if needed, and identification of the tracks. And don't forget about models. We can actually interact and augment these models with live surgery across space. There are programs that allow real-time connectivity. Here's an example of one where a surgeon in London is taking a surgeon in Greece through their first robotic case, and he is with them more than any proctor standing off behind the surgeon ever was. He's able to engage with the surgeon, speak in real time, draw and annotate on the screen, and hear each other in two-way conversation. Here is a clip of me using one such program, doing a Tatia knee with another surgeon in Amsterdam. It's a live feed from a headlight cam, which transmits my view remotely to any Wi-Fi enabled device, where you can speak, annotate, and superimpose a hand right on the software for the surgeon to see. It's the ultimate in proctorship when you're starting difficult cases or as a young surgeon starting your career. And artificial intelligence elements can also be used to help guide your surgery live. Augmented reality can overlay data and images over a patient's body to help improve your successful outcomes. Virtual reality can pull a surgeon into the case to help investigate from outside of the field. And the Internet of Things, or IoT, can use the two combined to connect inexperienced surgeons with specialists or coaches that can help with complex procedures remotely. This is really beneficial as a young surgeon. This is a VR environment created from an MRI that the surgeon walks through. It helps create a detailed anatomic model of a rectal cancer at the same level during the case. This detailed understanding may not be possible with just a film. And an AR overlay after a pelvic dissection can be used to validate that no vessel or nerve injury occurred. AI is not perfect. It still can't distinguish between a chihuahua and a blueberry muffin, but it is helpful in the operating room and beyond to learn from our cases. And after the case, it's extremely important that you review your performance. Acknowledging and identifying inefficiency, errors, and near misses, this is how we get better. And like great athletes, great surgeons want to be told the truth. The most feasible and objective measure of performance review is with video. Video doesn't lie. Video provides objective data that you can segment into the steps of the operation easily to review, like an athlete watching their films. Athletes use coaches to improve their performance with videos. Coaches can help identify the areas for improvement, followed by deliberate practice with customized exercises, repetition, and immediate feedback. This method of training is seldom used in healthcare, and this deficiency leads many surgeons to plateau in a state of proficiency, though the skills could be developed to achieve elite performance. Video-based coaching is a structured approach to peer coaching based on regular facilitated video-based review of operative performance. Video-based coaching matches an individual surgeon with a surgical colleague who's been trained in the core principles of coaching. The pair uses a video recording operation by the participating surgeon to examine the operative performance, including technical, cognitive, and the interpersonal skills and communication. And then during a series of video sessions, they identify individualized performance goals, evaluate current performance, and design an action plan to advance towards these goals. There are collaboratives and societies internationally that are trying to create these programs, and data is accumulating on the benefits. The feasibility, key steps, and coaches' perspective have all been reported, but results to date are scarce on the individual's performance improvement. Currently, there's just one published work that shows an association between video performance review and patient outcomes. It's difficult to set up the structure and difficult to implement currently, but we're working on them. And there is a video coaching in a box that's available. There are several companies that have come out with these programs where you can upload your videos directly from the operating room, saving you from having a drawer of discs or a box full of videos to a secure platform. From this, you can make a personalized video library for all of your cases. The patient health information is anonymous, and there's automated step segmentation, so you can go to particular parts of the cases and compare how you've done through them. You can get anonymous expert feedback, and you have the ability to edit and annotate your videos, as well as having a private dashboard made for you that has meaningful analytics by step and by procedure. A huge amount of personalization is possible with these coaching models. You can select your procedure, you can select your step. The key steps, again, are automatically segmented for you, so you don't have to find where your anastomosis is or where your lateral dissection is. And after being reviewed by the experts, keywords are pulled out, and it's graded for you on a private scorecard using validated measures such as goals or gears, whether it's robotic or laparoscopic. Here's an example of a private dashboard where you see the validated custom performance metrics so you can track your progress, get some clinical insights, and some meaningful analytics by step and by procedure. It's extremely important for young surgeons as you're starting out. You don't know how you're doing unless you go through and grade your performance. And just recording videos doesn't mean anything if you don't go back through them and look at your progress over time. Several companies now also allow an augmented reality that can be overlaid on your video. You can use these AR tools to see what would happen if I retracted here, if I cut there, if I used a different port location. And then you can study your actual and augmented steps to help prepare for your next case. All really valuable tools that are available now. So to end, innovation's happening. As young surgeons, it's important to embrace it for performance improvement and for being your best selves. So that's what I have. Thank you.
Thanks very much, Debbie. That was a lovely talk. Really insightful ideas on changing the model for surgical training. If people want to post questions on the chat function, we can ask some questions. I might start off with a quick question. How do you factor in kind of a busy surgical practice, the time for the video-based coaching? Have you any strategies to integrate it into your clinical practice and for residents?
Sure. For residents, I do it as research. It was sort of the Trojan horse that got it into the institution to begin with, because everyone's hesitant to invest in any technology. And we make it part of the structure. Everybody wants feedback. Feedback is very difficult immediately after a case, because if you think about it, the attending may go off to leave the residence to finish closing the abdomen, they do their dictation, they transfer the patient, and people don't meet up again. By having a set academic day each week to go over the videos together, that's a way to do it, and that's just built into the education structure. I think that most programs have an education day, so it's invaluable on that day. By providing the programs that sort of have the coaching in a box, the trainees can do it on their own time, at their own convenience, and you're able to access, if they provide access or if you set it up for that, to see how they're doing and ensure that they're doing it. And for preliminary results, there are significant improvements in operative time and efficiency with residents that are using these programs versus those that don't.
Well, and Debbie, I enjoyed your talk very much. So I was trained more than 25 years ago, and none of this was available. I was trained classically hands-on live in the operating room or with the older surgeon there. Mm-hmm. Now that has its advantages, but the main disadvantage is that if I am a young resident, I want to focus on right hemicolectomy, I have to be lucky to have a right hemicolectomy that week or two, and isn't these tools you are describing, they're much more cost efficient. You can focus 1 week on the right hemicolectomy if you wanted to, and you can see 100 of cases. So isn't it much more cost efficient, you think?
I think it's cost efficient, but it's also time efficient. I think that the way you trained is probably the ideal. I mean, if I could have my druthers, I would want to stand next to you and operate with you my entire life, but it's just not the way that training is anymore. There are duty hours where you have to leave the hospital, and in that time, you don't know what cases you'll see. And there's also time limitations for training. It's not when you think that your apprentice has become efficient and is ready to operate independently. In the US, at the end of 5 years, or in the UK, at the end of 8 years, you're done your training. And you don't know what you're going to get in that time span. So we have to find these resources out of the operating room to help us be confident.
When I was looking at the models, I think they're very useful very early in the training phase, because in real life it's much more messy than a simplified model. Wouldn't you agree?
Yes, and sometimes you can say, if you cut that vessel, oh yeah, that's what the model showed me. But for things like fistulas, they're extremely helpful. For things like reoperative rectal cancer surgery or reoperative cancer surgeries, they're very helpful to see which vessels are left, which vessels are now the main tributaries, any aberrant nodes that may be available. It's good for planning.
Well, the part that you showed about making a video and then submitting it to your peers, or
mm-hmm.
So of course you mentioned this for training purposes, but I was thinking it's lifelong learning.
Lifelong learning.
Are surgeons, established surgeons who are well beyond their training, are they expressing an interest to do this?
They are. And we're seeing trends where surgeons that hadn't even done laparoscopic training are moving towards robotic training. And the videotaping is just done automatically. You don't even realize it's being done. They're sent directly from the equipment into a secure cloud where they're segmented. So it's not distracting you during that. And then whether you want somebody, if you're an established surgeon, it can actually protect your anonymity. You can set it out to be peer reviewed. You don't know who's reviewing you. They don't know who's being reviewed. But we do say that we're lifelong learners. I mean, we should continue to strive to be the best technical surgeons, and this is a tool to do it.
Yeah, I think the anonymity is a very good thing, because as an established surgeon, I would be a little hesitant to get feedback from you're doing.
And it's funny, you know, we'd like to think that we don't have egos, but this just takes the whole element out of it so that you can really just get better.
There's an interesting question on the chat there from Rita, who is asking about how does video recording distract surgeons during the process? Have you found any issues with distraction with some of the kind of live tools?
No, you don't ever even know that they're recording because it just happens automatically from usually a small box in the tower.
Yeah. And then there's another question from Jan Mihai, who's asked about adopting these models to more conservative training programs. So in a more conservative system, how do you even start to think about introducing some of these innovations? What do you think are the low-hanging fruit to start with?
I think that the low-hanging fruit is always to introduce it as a research project, because institutions always want to improve their profile, have publications, and then it puts a structure on it. So again, it's kind of like a Trojan horse to sneak it into the institution. And companies will often give it to you without cost or at a highly discounted cost, even if you're designing the program independent of them, because it gives them presence in the literature once it's published.
And isn't it so that these techniques do not replace standard hands-on training?
They don't replace it, they just augment it.
They add it, yeah.
And there's a question from Carmela on the group about, I think, more about consent. So with the video-based training programs, where you upload the videos, do you routinely consent the patients for that, or how does that work?
Consent forms, at least in the US, routinely have something that says that do you consent to being taped for educational purposes. All of these programs are completely de-identified. As soon as you come out of the body with the camera, it pixelates to a point where you can't recognize anything. Some have no audio, and some that have audio, again, have programs that de-identify and take any established elements out so that you can't recognize the surgeon, the patient, or any of the operative team. So all of the elements of compliance are obeyed with.
Excellent.
I see another question that I had also written down. So can these techniques or tools be used to enhance patient-doctor communication? So there are a lot of other skills too that a surgeon requires. So I've written down empathy, curiosity, being a team player, communication skills. I think communication skills are amenable. Where I was working previously, we did a test in video capturing with patient consent, the discussion from me with the patient, and then my colleagues were analyzing me. So I think it can also be used, this is mainly used for students, but it could also be used in training, in communication, don't you think? Is that happening?
It's something that I'm personally working on. You know, when people ask me, what is it that I want to establish in my career, I can say that I want to improve the patient experience in surgery. And I think that some of these tools that the patient can have at their fingertips to go over as many times as possible to interact with the healthcare team or the surgical environment can really help improve their experience in the privacy of their own home, where they may be, you know, not shy to ask questions, or questions come up after they leave the doctor's office, or things that they want to know that they didn't even want to know. Often when you're talking to a patient about the procedure that they're going to have, once you tell someone that they have cancer or that they need surgery, they don't hear anything else. So this gives them the power back over, you know, their care, to have all of the information in a way that they want to access it. And we're just developing multiple ways to access it. Do you like words? Do you like pictures? Do you like video? Do you like VR? Do you want an app? They're all feasible.
So when I see 10 surgeons do a right hemicolectomy, they all do it differently. They have a different order of things, and it all ends well. So don't you run the risk of putting too much steps that you're going to be too strict and this is how it should be done?
Well, I think it's how it should be done for that individual surgeon, for them to be able to do the best procedure the way that they do it, because there's always room for improvement. It's not to say that they have to do it the way I do it. They can do it the way that they do it and just review how they're doing it. Because if they looked at the way they did it from procedure 1 to procedure 10 to procedure 30, there'll be massive improvements and changes.
The Hawthorne effect. That is an interesting. So,
sorry, go on.
So Catholics have in the classroom when I was a little boy, there was this big eye of God on the wall that was watching over us, that made us feel we have to be careful here. So Rida Azigulova says, what about the Hawthorne effect? We perform better when someone is watching us working. So what if these videos provide only the best versions of the given surgery, but in reality, the quality of the surgery will be different? So what does that mean? That the videos are only the best parts that you want to show?
We're not talking about the videos that you're going to show in an invited conference lecture that you've edited down. This is recording everything. And I would encourage you to record every procedure that you do and have them. Most people, at least in the US, have been encouraged to do that for years, but it's led to having drawers full of CDs and thumb drives all over it. And this is just an organized way to have them and be able to pull them out quickly and easily by procedure. So I'm not saying that you should only tape your best procedures and use that. That's like, quoting Dr. Beats's complication rates when you're a new surgeon going into practice. This is, being honest with yourself and your skills and open to improving and taping everything.
Yes, if you send in your best videos, you're only fooling yourself. You should actually send in your worst videos. And ask people, where did I go? Where did I took the wrong turn? Yeah.
I mean, those are the videos I want to see. I want to see the nightmares in the OR videos. I don't want to see these beautiful curated videos, because when you operate enough, everyone has complications and everyone has difficult patients, and we want to know how to get out of those situations and have the best outcomes for our patients.
Have you noticed a difference beyond the kind of technical improvements in the residents in terms of confidence and satisfaction and feeling ready for practice?
Absolutely. Absolutely. In self-confidence, in coming into the OR prepared, knowing the steps of the operation. I mean, without this, I remember going in and writing on the whiteboard, the 7 or 8 steps of the operation and ensuring that they knew what we were going to do when we progressed, and saying, here's some videos, make sure you watch this. In this format that they can do in their own time, at the tip of their fingers, on whatever they have available, they use it. They do want to get better. They do want to learn, and they come in prepared, and they'll do more if they're prepared. So everyone benefits.
So the residents, they felt better prepared, or they scored better. So how did you also ask their teachers what they thought of their residents?
We're working on that. Yeah.
Can you convince older surgeons who are skeptical that it really works if they see that they're improving much faster?
Yeah, and there is a validated scale that looks at that performance improvement for non-technical skills. So we're working through that. We're capturing some data.
Debbie, I have just another question for young surgeons who are trying to integrate this kind of research into their practice. And just setting up the research infrastructure, going about applying for grants and getting stuff started. Have you any tips and tricks for getting your research program started?
Yes. It's really hard. Don't give up. As doing this at two major institutions that tout themselves as major research places where you really have no help. I think first knowing your personal plan and what you want to do. And, having a wide view of, are you going to start with your institution's grants, which is a nice, easy target because most institutions have small seed grants. Do you have to earn your time off for research, or do you work 100% and then research is something that you have to do in your nights and weekends? Or if you have grants, can you buy back your time from your salary? So it's sort of knowing yourself and what your goals are on a 3-year spectrum and what resources are available when you're walking in. Is there a database for your institution? Do you have national databases that you have access to? And who do you have to help? Like, what's your own skill set? Are you able to do your own statistics, or is there a biostatistician there? Do you have residents and medical students that will help pull data? And the low-hanging fruit to start with is always just looking at your institution's outcomes at a baseline, because then you have your targets for quality improvement. And you can figure out, where are the areas that I can concentrate on? And everyone has their own interests, whether it's in surgical education or IBD or cancer. There's a baseline to start with after you do those initial audits. In Europe, there's amazing registries for cancer and collaborations that you all do so much better than we do in the US. And I think that those are also easy ways to start getting research established and learning how to write and seeing what others do, because everyone's busy and you can be busy at different time points and work together and get collaborative papers out. And it will also increase the power. So if all you have is your institution's data, you can talk to your mates that have their institutional data and it exponentially grows. And, then that's your second paper. And then looking at your trends versus national trends and writing the grants to be able to establish the cancer registries could be your third paper. And then mining through that. Once you start establishing and finishing work, you'll establish a reputation for yourself where others will want to work with you. And it becomes a little bit easier so that you can pull data and share your plan with other people so that you can see your vision through them. They can start to develop their own questions and it just grows like a tree. But it is hard. And I would say don't give up. And if there's someone whose work you like or admire, reach out to them, because surgeons have all been there and we're very likely to help and to provide tips and tricks.
We have an interesting question that takes us to another direction. Theo Wiggers, thank you, Theo. Mm-hmm. He states that in Africa, a lot of the surgeries are performed open. Mm-hmm. They don't have a lot of the high-tech skills around. He says mm-hmm. This is also true for residents doing minor procedures in a back room somewhere in our setting. And that should be thought properly too. So how should you solve this problem? I guess cell phones are everywhere, so that could be, is there a solution for this?
There are several companies now that are working on solutions specifically targeting low and middle income countries using very low cost laparoscopes that are disposable. And if there's any Wi-Fi connection, then the video feed can be transferred over that using headsets, where it's the same thing. It does rely on a cloud for anonymity. So even with open surgery, there are tools and scalable tools where we can help. Companies are also willing to donate to help with resident education. It's something that the societies can help with funding for. I know it's been done in the US and I think ESCP and others have helped with that. So it's a way to start attacking the problem. It's not solving it yet, but if you need equipment, I would say reach out to companies. I'm happy to talk to you offline for some resources that I know, but simple headsets, if you have a Wi-Fi connection or someone that can film on a cell phone outside of the field. Cell phones are sometimes hard with open surgery because you really need to be right over it. but there's solutions available.
Okay, thank you.
Andreas, do you have any other questions or?
Yes, first of all, thank you so much, Debbie, for your inspiring talk. Yeah. It was wonderful to listen. I very much like the quote, "Great players want to be told the truth," because to my experience, that is sometimes an obstacle, right? That also cultural-wise, people are not so used to be direct or more indirect, and your techniques and your project that you showed is overcoming these hurdles very nicely. I have some questions here on the Q&A, which we have not asked yet. So there's a question from Andrea Cordos. Can you tell us how these tools could be accessed for people in Europe wanting to join such projects?
Sure. Most of them are accessible online. I would say, if possible, to buy it through your hospital or your surgery department instead of as an individual. It's probably much better priced. And if you're not able to pay for them, again, trying to contact the companies through research. And it's the big companies that offer the big product. It's the Medtronics, the Johnsons & Johnsons, the Ethicons that are readily available. And then small companies also have products. So when you go to conferences, now that we're having live conferences again, go and visit the technology booths that are being set up and see what people are offering. Have these available.
Thank you. Then there's another question from Javeria Amin. What are strategies to deal with untoward complications during such procedures? I believe that question goes towards the direction in all your training sessions. What are you doing when there are some complications ongoing, which might be very relevant?
Complications as best as you can for a standard of care. I mean, it's what you do in every case. And then you go back afterwards and you review. And that's the beauty of having that. What happened and how do I stop this from happening again?
And then there's another question from anonymous attendee regarding robotic surgery. What is the best method of training from your point of view?
Repetition, pre-training, getting on the simulators, getting on 3D models, going in, watching cases, then acting as a bedside assistant for a number of cases so that you can anticipate the move, then getting onto the console as a second surgeon if you have a teaching console where it can be swapped back and forth until you can show that you're facile with the movements and comfortable and moving the camera, moving your arms, doing the dissection, and then just doing cases. Repetition, review.
Great, thank you. And the last question, the Q&A, which is not answered yet from Javeria Amin. Do you know any model of training obstetrical procedures through video coaching? Do you have any connections to this field?
I personally don't, but I bet that the companies do, because this isn't unique to colorectal surgery. It's for any surgeon. So reaching out to local reps, I bet that they could set you up, or mentioning it to obstetric and gynecology practitioners in your hospital, they may know.
Thank you for your answers. And a last question came in just right now from Gennady. Is it possible to switch from open surgery to robotic surgery without having any laparoscopic skills?
It is. You're going to learn laparoscopic skills or just transferable minimally invasive skills in the process, but it's literally what the urologist did for prostate. So it is.
Thank you.
So I wanted to ask you, there are several commercial people, they're trying to provide these services of online libraries where you put your videos in there. So there are several options. And I'm always a little worried. I mean, are they doing this completely altruistic, or do they, where's their profit? And is there any worry? And don't we have a setup that is not linked to one of the big companies?
So I think it's good to always be worried. This is patient data. You guard it with your life, and you give the patient every ounce of respect they deserve. So you have to ask the proper questions. Is it protected health information that's extracted out of it? Is it compliant with all of your hospital and national guidelines? Who owns the video? Everybody wants video. Every company that enters your hospital is going to ask you for video. And the reason is because they want the data from it. So it's not so much the cases, it's the patterns and the data points that they're trying to extract out to eventually develop these machine learning models for predictions in surgery. And that's why everyone's asking for data. So do you own your data, or do they own your data? If you upload it, are they allowed to access your data? Or is it just your library? How is it stored? And also check with your hospital, because this is a growing field. And in the US, there's differences hospital to hospital, as well as national HIPAA guidelines and national consent guidelines. But without established standardized procedures for taping and upload, people can say that anything is a violation. So you really want to make sure that you go through and dot your I's and cross your T's over how it's uploaded, how it's stored, who can access it, who owns the data, are you able to take it back, and the rights to it.
So are you aware of any of these platforms that you can actually store your own videos and you get them back and you cut apart and you edit for a presentation, that you actually keep them stored there for your own use too?
I haven't cut apart any on their platforms for presentations. I usually store them whole, so I can go back and pull anything. But yeah, the major players are all coming out or have those available now.
Okay.
But it's good questions to ask. Where is it stored? Who owns the video? Are you compliant with national guidelines?
Thanks very much, Debbie, for an absolutely outstanding talk and for a very fascinating discussion on the nuances of data protection and surgical education and everything in between. I just want to thank everybody for joining us this evening and remind everybody that this is part of the ongoing series Legends in Surgery, and our next legend is Nisha Ahuja on the 6th of December, so I do hope you can join us for that. And don't forget to register in advance. It's free, but you do need to register. And a huge thank you again to Dr. Debbie Keller for joining us from the USA.
Thank you.
Bye.